Good morning, everybody. Welcome to Grand Rounds. We are continuing our series featuring some of our magnificent third-year residents in the internal medicine residency here at WashU. First up today, we have Dr. Vinathi Polamraju. Dr. Polamraju obtained her bachelor's degree in biomedical sciences from Texas A&M. Afterwards, she went just a bit farther south and a little bit east to Montgomery Medical School at University of Texas, Houston, where she obtained her medical degree. And then she came here for residency. Next year, she's currently applying for a GI fellowship, and super excited to potentially work with her in the future. Today, she will be talking to us about kind of how the digital world is shaping healthcare. As a reminder, we do have two speakers today, so let's please save all questions for both speakers to the very end. And please help me welcome Dr. Polamraju.
All right. Thank you. Can everyone hear me okay? Okay, awesome. So like mentioned, and thank you so much for that great introduction. That's never happened to me before. Okay, I'm going to be talking about the digital transformation in healthcare. And I want to give a special thanks to the division that we have here at WashU, actually called the Digital Intelligence and Innovation Accelerator Program, filled with a bunch of excellent faculty and leaders as well, particularly Dr. Payne and Dr. Lai, who kind of helped give some suggestions and feedback for the rest of this presentation. So I first want to start talking about why I elected to talk about this topic in particular. And it kind of brings me back to earlier this year in clinic. I had a patient who came in with signs and symptoms of just not being able to fall asleep very well, waking up kind of drowsy, decreased concentration, low energy. We did the routine workup for moderately severe depression, biochemical testing that was normal, referred her to therapy, and then started her on medications, and then set her up with telemedicine follow-up. So I'm seeing her in clinic, or virtually in clinic, about 2 months later. And she tells me that she started noticing a change in her overall symptoms, and that she actually has a piece of technology that she purchased that tells her that things are getting better. So she points out this ring and then pulls up pictures in an app that kind of looks similar to this. And this ring on her finger is tracking things like her activity balance, her sleep balance, her resting heart rate. And she said, the reason I came in about 2 months ago was because my app told me that things weren't looking too good and I needed to see my doctor perhaps. And since she started medications, since she started having her therapy sessions, she's noticed that these numbers have overall been improving. And I thought to myself, what a great way to be able to have more of an objective way for not only patients, but physicians to be able to track the response and progress to medications and treatments, and for patients to kind of corroborate that as well. So then I did some Googling after that visit, and around the same time came this article that was published in Sleep Medicine, where they looked at 96 different Japanese participants and compared this ring to a traditional polysomnography and evaluated the validity and the reliability of this ring when compared to traditional sleep studies to diagnose sleep disorders. And they found very high sensitivity and accuracy rates. So that's kind of what led to the interest to present this topic today. And then I went way back, think the 1970s, to this first AI incorporation into medicine called MySyn. It was actually produced as part of the doctoral dissertation for a professor over at Stanford. And I kind of want to show you how it looks just because it was kind of striking. It's an AI model that helps determine the culprit bacteria based on a series of questions. So you start off by filling in patient demographics, and then it asks you yes or no questions based on a patient's culture data, and then gives you its top 3 to 5 differentials and a reasoning as to why it thinks, based on all the information you've given it, that the diagnosis is blank bacteremia or blank meningitis. And then it takes it a step further and tells you what antibiotics you should give based on the most likely diagnosis, and then also adjust the dosages of the antibiotics to the person's body weight, which I thought was very cool. And so did people at Stanford, and they did this expert review of 8 subspecialists infectious disease docs and actually found an acceptability rate of 65%. And so it was pretty accurate and pretty reliable, but it's not used in clinical practice right now, and there's no real iteration of this that's used commonly as well, mostly because of the ethical and legal concerns and the fact that this was way beyond its time. A major concern was that if this were to give you the wrong diagnosis and then you were to treat someone inappropriately, who does the blame fall upon? And then there was no real way to incorporate this technology into systems at that time. But since then, we've had kind of an outburst of a wide variety of digital technologies like the Da Vinci robot, smartphones, wearable technologies, and then the FDA approval of AI, and then the recent incorporation of ChatGPT, and then Google's launch of MedPalm as well. And now there's more than 150 digital health startup companies that are working to create technologies. And so when I think about the digital transformation, I think it's more than just the technologies that we wear and see, but it's really the incorporation of data analytics and innovative processes to reshape our innovative organizational strategy for not only the administrative side, but also the clinical side, to be able to make us more productive and help us engage better with our patients. So kind of setting the agenda, because this is a very large topic, we kind of talked a little bit about the background and the timeline. I want to spend the majority of my talk talking about stimulus for this transformation and then ways that we have already implemented technology to address these drivers, and then barriers to this transformation and why we as a healthcare community have been behind other industries in incorporating technologies, and then lastly, kind of touch on what this means for the 21st century physician. So the 4 drivers that I wanted to talk about were changes to our healthcare sector, changes in lifestyle, the transition from traditional medicine to more personalized medicine, and then the COVID-19 pandemic, of course. And there's multiple others, and just for sake of time, I'm talking about these 4. So firstly, changes in the healthcare sector. So according to the US Census, by 2030, which is not so many years from now, they anticipate that all baby boomers will be older than the age of 65, which means that roughly 1 in every 5 US residents will have hit retirement age. And with this rising age comes a rise in chronic medical conditions, where more than 60% will have at least 2 or more chronic medical conditions that will lead to rising healthcare utilizations, costs in the face of healthcare worker and physician shortages. So a way that Japan, which is my first case study, has kind of addressed this dilemma is by, quote, automating elder care. Let me see if this works.
A company in Japan is experimenting care robot, affectionately called Robert. The cute bot is being developed to help patients around the hospital. Robert can perform tasks like lifting a patient from a bed into a wheelchair or helping a patient stand up.
So I hope that was audible, but I think the video itself does justice to it. So Japan, I think, is unique because they're having to face the problem of an aging population in the face of low birth rates. So they've actually been working on inventing these digital robots since about 2010 with the help of over $300 million in funding for research and development. And what we just saw was called Robert, which helps with transfers at nursing homes. There's also another robot called Pero that serves kind of like a distraction aid or an emotional support robot. And then there's also another robot called Pepper that helps with physical therapy exercises. But when you look at kind of like national surveys, even in 2019, only about 10% of these institutions were using such robots. And so kind of a flash forward to the next portion of my talk talking about barriers, but clearly an underutilized piece of technology. And in addition to that, we have seen ambient note generation becoming talked about recently, being able to have a device in the physician room when you're talking to them that can then generate your note for you. Being able to generate automatic responses to patient MyChart messages that you can then review for accuracy and send off to the patients. And then also being able to develop an AI model that can summarize a very prolonged hospital course and use that to help make discharge summaries easier. But clearly in sight of all of this, a lot of research and development and privacy and security issues that still have to be addressed. And the second driver that I want to talk about were changes in overall lifestyle. So this paper in Nature actually talked about the early onset of mental health disorders, especially in children and young adults, rising to rates or ages as early as 12 years. And the need for increasing awareness and intervening early upon this particularly vulnerable population that has limited access to and barriers to receiving mental health care and resources. And one way, in a paper around the same time that was published in Nature, was using machine learning to predict mental health crises to be able to intervene earlier from the physician standpoint. So what they did is they used a patient's data regarding their encounters, their psychiatric encounters, hospital admissions, and they assumed that after the first crisis onset, there's this trickle of further crisis events that they defined as a crisis episode. And then after that episode, based on input from psychiatrists, they determined this arbitrary 1 week or so period where a patient is usually crisis-free. And so their goal was to determine when this next crisis onset or this next kind of red dot would occur to be able to intervene prior and prevent this downstream effect of further crisis events. So the way that they formulated this algorithm was by extracting patient demographics, ICD-10 codes, their hospitalization encounters, their emergency department encounters, and then developed this model that was tuned to query each patient's chart every week. And then based on kind of their risks and features and how often they've been needing to use healthcare resources, they were either categorized as high, low, or mid-risk every week. And then those patients who were determined to be at the highest risk were then kind of flashed onto a clinician's dashboard as important or think about. And in addition to kind of the patient's information, the physician would get indicators as to why they were probably at higher risk, your last patient note, and then questionnaires that you can fill out with the patient when you contact them or call them. And they did a 6-month prospective follow-up of this application, and in 64% of cases, clinicians said that it helped them manage their caseload and actually helped mitigate the risk of crises for patients as well. But I think there's a lot of work that still needs to happen in order to incorporate this more seamlessly into our electronic medical record. And then the third kind of stimulus has been this transition from more traditional medicine to personalized medicine. So the shift from using one standardized therapy for the average patient to now being able to develop a therapy based on each individual's genotype and genetic predisposition, and being able to target medications and therapies as such. And one way that this has come about is this digital twin, or the closed loop system for diabetes as an example. So in this particular situation, what happens is there's a continuous glucose monitor that's attached to a patient that measures blood glucose levels and then transmits that information through this glucose control algorithm. And when I looked at the first paper, there was about 7 pages of formulas like this that went way over my head. But after all of that data is kind of inputted into this algorithm, it sends a kind of like a brief update, for lack of better words for someone with no math background, to an insulin pump that then adjusts the amount of insulin that needs to be delivered to a patient. And that kind of happens in a seamless way that requires little to no patient interaction or feedback. And New England Journal of Medicine published this multi-center RCT in 2019, looking at 168 type 1 diabetics who were randomized in a 2-to-1 ratio to receive therapy either through this closed loop system or through a sensor augmented pump. And their primary outcome was looking at time within range. So keeping people within that 70 to 180 range. And they found that patients who use the closed loop system were about 11 percentage points higher within range, which is equivalent to about 2.5 hours per day less time in hyperglycemia and 13 minutes less time in hypoglycemia. And then also looked at an improvement in their glycolated hemoglobin levels following 26 weeks, whereas there was no change in those who used the control group. Let's see. And then a sub-study of this same trial published this year actually interviewed 11 participants who used that delivery system. And these are just some quotes that they had reported in their supplementary pages, that it was a welcome break from the day-to-day demands of living with diabetes and actually led to a significant improvement in their quality of life. And then the last driver that I want to talk about is the COVID-19 pandemic. I think we are all very aware of the devastating effects in terms of morbidity and mortality, but I think it also opened our eyes to the vulnerabilities in the healthcare sector as well. Things like PPI and sanitizer were suddenly prized commodities. And in addition to that, technology was used to kind of help create worldwide connections in terms of population surveillance, contact tracing, medical education, population, and just general public communication as well. And one technology out of the several that's emerged since the COVID-19 pandemic has been this hospital at home model. It's the ability to provide acute hospital level care at home. And it started with COVID-19, kind of expanded because of this Medicare and Medicaid waiver, and is now utilized to cover other conditions like COPD exacerbations, heart failure exacerbations, pneumonias, UTIs, cellulitis. And now a lot of different companies and hospital systems have been incorporating this into their workflow. And I hope you can hear this one. Oh, well.
Excellent.
Typically, 80-year-old Florence Sparks would be hospitalized for congestive heart failure, but instead, she's at home.
I'm getting better care here.
How is it better?
Well, I think they're more attentive. They're not rushed to see another patient. They give you their undivided attention like Manny just did.
Manny Mills, a community paramedic, visits twice a day. Sparks sees a doctor over a provided iPad once a day.
I think it's going up on the LASIK.
Oh, the LASIK, okay.
Going to twice a day on it.
And a nurse twice. They can also provide ready-made meals, care that's more comfortable for patients and more informative for caregivers, says Mills.
You really.
And this is actually widely used. Just last week, based on the CMS's website, there are more than 335 hospitals across 136 health systems and 37 states that actually use this kind of model for delivering care at home. And it's projected to double by 2026 if this waiver gets extended as well. So now that we've kind of talked about the ways that changes in the healthcare industry has driven these technologies, I want to talk about why we don't see these more often. The first kind of barrier that I think is pretty apparent is physician constraints, the fact that we have a high amount of workload to begin with, and being able to learn and implement other technologies can increase that burden. A lack of time, a lack of reimbursements, and a lack of just knowledge about digital technologies, how they work, just that algorithm and that math that I pulled up, being able to kind of understand and troubleshoot technologies that way. Another one being patient limitations. While a lot of our patients have access to digital resources, it's not widespread, and it can lead to a lot of misuse and misunderstanding. In the closed loop insulin system, 36% of participants said that their biggest complaint was having to troubleshoot their own insulin pump hardware, because they're the ones that live with that machine and that device 24/7, and it's hard for them to be able to kind of troubleshoot devices that way. And then obviously the developing digital infrastructure. There needs to be, I guess, better interoperability with that machine learning algorithm to diagnose mental health diseases and disorders and crisis events and so on and so forth. You need to be able to seemingly incorporate that into the electronic medical record without kind of encroaching upon a patient's privacy and security. And then organizational drawbacks, the fact that we as in medicine have a resistance to change. We really like our RCTs, our multi-center, 10,000 patient population papers to be able to guide practice guidelines. And I think a lot of that leads to reluctance when a lot of these technologies have been understudied when you kind of set it against that standard. And then the potential complications that this leads to is a rise in administrative tasks, increasing health disparities. Are we going to provide more productive and effective care for patients who have access to these resources when compared to those who don't? And with a rise in data that you have and the ability to run and rerun this data multiple times over, does this lead to overdiagnosis? Are we chasing something that may not actually be there? And then lastly, what does this mean for the 21st century physician? And just kind of as an overview, because I've kind of already touched on it, is really being able to equip ourselves with an interdisciplinary workup that includes not only the patient, but also our tech colleagues as well, to be able to create ways that we can incorporate these technologies into our practice guidelines, being able to critique the quality and the effectiveness of these technologies and voice inefficiencies that we note in our day-to-day that we think could be better served with digital technologies, and then advocating for laws and regulations that keep our patients secure and safe as well. And then adapting, recognizing that the healthcare landscape is subject to change as the COVID-19 pandemic shook the entire landscape prior, and appreciating that medical education is likely to change, and being open and kind of recognizing that this could happen as well. And then kind of a small plug, I kind of mentioned it earlier, but while I was doing my research, I actually came across this division, like I said, filled with great expert professors and physicians and staff as well that work to kind of incorporate digital technology at our campus right here. And they have great ways and resources on their website as well, where they help provide funding for projects that are trying to look to do similar things. And they actually have coffee hours too, if anyone's interested, but just something that I came across. But that was my talk.
Of Dr. Sajal Tiwary. Dr. Tiwary attained his bachelor's degree in microbiology from Princeton University. He then came here to WashU to obtain his medical degree, and we were lucky that he decided to stay here to be one of our great internal medicine residents. Next year, he plans to be an ID fellow, currently applying to ID fellowship. From what I've heard, he is very, very sought after. So I think that just kind of speaks to the quality of resident that he is. Today, he's going to be talking to us about novel blood-based markers, biomarkers to identify pathogens in the context of, as you can tell, his interest in infectious disease. So please help me welcome Dr. Tiwary. There you go.
Can everyone hear me okay? I'm naturally very loud, so I will not be able to tell. Fair warning, my slides aren't nearly as pretty as Vinathi's. And if there was a 1970s AI model that basically agreed with 60% of ID fellows, then what are we doing here, right? But hopefully this is still somewhat interesting and useful down the road. So, as Dr. Daniel said, I'm a third-year resident here. Interested in ID fellowship. If you know of any jobs, please give your boy a shout out. And I'll be discussing some research I did today under the auspices of the C-STAR program run by Dr. Gage and Dr. Eisen. If you're interested, I'm happy to talk more about my experience later on. So. All right, disclosures-wise, I unfortunately don't have many as of now. All of the research you're going to see here was funded by grants that are internal to WashU, nothing external, no conflicts of interest to be worried about here. Learning objectives-wise, we'll first be assessing some existing methods for diagnosing bloodstream infections, the blood culture, of course, being the most notable one, and some other rapid assays that have emerged recently. Then we'll shift to the data that we've obtained at our group for some new rapid assays to diagnose these bloodstream infections, and then evaluate what our findings indicate in the setting of all of these other markers and what clinical practice looks like right now for diagnosing bloodstream infections. think it's important to say what I won't do, which is discuss kind of the pathogenesis of bloodstream infections and all this whole alphabet soup of different types of infections and infectious states like sepsis and bacteremia, septicemia. I won't be talking about all that. Nor will I be talking about prognostication for these types of markers or treatment and as well. We'll mostly be talking about diagnosis. Here's a little outline, kind of get you guys oriented to what's coming. And we'll start, as I said, with just a little introduction to what diagnostics looks like for bloodstream infections. And most people usually like to orient their talks with a case, but I want to talk about multiple cases, or like a prototypical case that I think we all have experienced at some point or another. So this, I'm sure, is very familiar to you guys. You have someone, they come up to the floor, to the emergency room, wherever, they look sick, you are concerned about an infection, you get blood cultures, and then you see this for God knows how long, like a day, this half moon just stalks you. You maybe start some antibiotics because you're a little worried, and then it's just a waiting game for ad nauseum. You don't know how long, you just hope that they get better. Maybe you see something, and oh my God, this is what you see. A day later, man, it's not even over. There's still a little P2, but there's more coming. Everything just feels like it's on fire. Brought into Miro Dapto. I'm just kidding, don't do that. That's the feeling you get, and one possible outcome for this whole situation. Or maybe it's been 2-3 days and still all quiet on the Western Front, and you're like, okay, maybe it wasn't bacteremia. Maybe it was something else that was the problem, and I can stop antibiotics. I can kind of move towards these other avenues for treatment. And then, of course, there's the third case, which we are all kind of familiar with when you see this. And it's like, well, I don't know, what do I do with this? I mean, is this just 1 out of 2? Is this real? Is this fake? Does the patient still look very sick? And then, lo and behold, a day later, you see, oh, it's Staph hominis, single blood culture contaminant. Okay, that's fine. And then once again, you feel like you are relieved of a burden, and you can move on with your life. That, I feel, for the most part, and maybe I'm oversimplifying some, is kind of what our canonical experience with looking at bloodstream infections and blood cultures is, at least at Barnes. I've only been at Barnes, so. And I think one of the issues with this type of approach is that we often treat blood cultures like they're the word of God. That they're just dogma, they're incontrovertible evidence for an infection or lack thereof. And I want to say, I know if most of us probably have worked in a lab at some point, you know that that's not true. Lab assays are inherently flawed as well. Not to say anything about labs, but I think it's important to take things with a grain of salt sometimes. So, blood cultures themselves, I found the statistic, and I was pretty startled by it. But some studies estimate that about 50% of positive cultures that we get are contaminants, or what we deem as contaminants afterwards with our clinical decision making. And beyond just that, there are other issues with blood cultures and what we think are flaws with blood cultures. They do require a certain inoculum, a certain organism load for you to actually adequately grow them. Granted, it is quite sensitive if you do get them, but this has led to higher volumes over the years of blood cultures being drawn. You have to incubate them correctly. If it's a fastidious organism, you probably won't grow it. We've all heard culture-negative endocarditis, which just grinds my gears because obviously there's something there. You just can't grow it, but negative makes it sound like there's nothing there. Contamination risks we discussed. And of course, the biggest thing, as Kermit the Frog demonstrated, is that it takes a long time. It just takes so long sometimes. For almost 3 days to get organism identification, to get antimicrobial susceptibilities back. It can be really taxing, and of course this can lead to a lot of adverse effects down the road if you have people on broad spectrum coverage to treat some sort of nebulous possibility of an infection without having actually some sort of data-driven process for treatment. This was an interesting report from the CDC. This feels like an underestimate, but 28% roughly of antibiotics are considered unnecessary, usually in hindsight, of course, once you have your culture data in hand. But of course, as we all know, when you're treating a patient who's actively ill in front of you, you gotta do what you gotta do. And the most ominous side effect or outcome from this is the rise of MDR organisms, which we're all also familiar with too. So this has led now to kind of this new industry of rapid assays that kind of try to counteract everything that's problematic with a blood culture. And there's two major parts of the pathogenesis of a bloodstream infection that these assays seek to investigate further. The first is just in identifying the organism up front. These are usually DNA-based assays. You guys have probably all seen this at some point or another. The ones we have seen more at Barnes are the Verigene, the BioFire. There's some other ones in the pipeline as well, like the pneumonia fish. Accelerate Pheno test, it's got some interesting data coming out now. They're trying to actually put it in the clinical space, do models for like cost benefit, et cetera, et cetera. So That's one way in which you just find out what the bug is, you find out what it's susceptible to faster than a blood culture will tell you. The flip side is what I'm dubbing then sort of infection syndrome identification, or essentially looking at whether or not a patient is infected. And this is typically contingent on looking at factors that the host produces in this host-pathogen relationship. So things like procalcitonin, which you guys are familiar with probably. We don't really use it here that much at Barnes for reasons I won't go into, but it's more of a popular one nationwide, worldwide even. And then other markers of the sepsis state. So things like presepsin. There are a lot of multiplex panels out there that look at multiple genes, usually immune modulators that are upregulated or downregulated in the setting of infection. That can help you figure out whether or not someone has an infection, has a bloodstream infection, has something for you to worry about. The problem with these, at least the ones that we have so far, are that one, as I said, they can be low expensive. Especially these DNA-based methods, they can be limited by the probes you have against pathogens and your targets. They can be nonspecific sometimes on the flip side too, especially with these sepsis types of biomarkers, because as you all know, there's many reasons that people can be inflamed aside from just an infection. And the most difficult thing is that we don't have a lot of studies right now showing that there is an improvement in what I'm calling hard clinical outcomes, things like mortality, length of stay. If anything, the thing that changes the most is time to de-escalation and time to identification of the organism, which makes sense. That's what the assay is designed to do. But that doesn't necessarily always translate to some sort of improvement for the patient. I don't think this is necessarily an argument against just abandoning this effort. I think it's just that we haven't found the right biomarker quite yet. Here's just a nice, pretty little graph showing a lot of these different types of assays across these three axes. So specificity for the organism in question and sensitivity for picking them up in the first place. And then turnaround time here is on your y-axis. So the ideal test would be one that has the lowest turnaround time, a very high specificity, and we'll here consider low. You don't need that many organisms in order to actually detect them. So something in this quadrant here. And we have a couple of assays that are in the pipeline for this, but as I said, they are also still expensive, limited by the probes and the organisms that they target, and they still need a lot of time for us to be able to figure out whether or not they'll have clinical improvement. In terms of the sepsis state, they're looking at the host response to an infection. This is a lot of words, a lot of numbers, but I'll draw your attention here to biomarkers such as CRP, leukocytosis, procalcitonin. These are all things that we use, and as I said before, especially for the first two, can be non-specifically elevated in any inflammation state. So their, of course, sensitivity may be a little bit higher, but the specificity is usually down in the dumps. And to kind of illustrate just how many targets we've tried, how many different possible targets there are in terms of looking at host response to infections. There are many, and they have been investigated, and oftentimes, as I said, can be quite nonspecific. So it's a tough question. It's one that I think can yield a lot of fruits, but it's something that will just take some time, and it's a kind of a race to finding the perfect biomarker, which is where we come in to also join this race and look for biomarkers ourselves. So our goals were to specifically look at bloodstream infections, bacterial bloodstream infections for simplicity, and to look at protein-based biomarkers because these tend to be faster assays, cheaper assays than, say, something that's more nucleic acid-based for testing. And then we wanted to correlate these with known infection data based on blood cultures data that we had obtained from patients here at Barnes. And then compare this to established assays, namely procalcitonin, and see how it performs or underperforms compared to procalcitonin. So for our patient cohort, we looked at only ICU patients over the age of 18 in any ICU here at Barnes. The criteria for inclusion were essentially related to the sample quality itself and the data of the sample that we drew. So the culture had to be drawn during admission. And the reason for that is that we needed blood samples from prior the day of the blood culture draw as well. This would allow us to look at a baseline level of the protein in question, and then we could also see if it goes up or down when the patient becomes infected at the time of the blood culture draw, and then to see if it downtrends or uptrends after the blood culture draw as well. So we wanted all three time points, and it's unfortunately difficult to do that if someone has a blood culture on their first day of admission. We did not exclude patients who had a positive blood culture prior to this, what we're calling an index culture, this culture of interest. As many of you know, we have a lot of patients in the ICU who stay there for weeks, maybe even months. They have recurrent bacteremia. We recurrently treat them. We didn't exclude those, unfortunately, just because of the availability of samples right now. In terms of the lingo that you'll see in the next couple slides with my data, we have essentially 3 buckets of time points. The first is the most important one, is the day of the index blood culture. That's the day of the culture of interest, and that's day 0. I'll also refer to it as the index culture day, as I said. Any negative day, that is prior to the day of the index blood culture, so day -1, day -2. And then days after the index blood culture will be positive numbers, so day 1, day 2. For inclusion in our study as well, for the blood sample at least, it had to be a sufficient quality and quantity, just to kind of simplify it. So this did lead to some patients not having samples at all time points, purely by virtue of the fact that they didn't have enough leftover samples from those other time points. So. In terms of the culture results that we got, we had gram-negative bacteria, gram-positive bacteria, as you'd expect. Sometimes we had nothing growing at all from the blood culture to begin with. And then we also had some polymicrobial and fungal infections, which I said before we were excluding, just to kind of simplify things. In order to analyze the data and to actually be able to extrapolate our quantitative findings for these biomarkers, we had basically 2 steps of analysis with these blood samples. The first was a proteomic screen that I did with the help of the MTAC over at the Genome Institute, where we essentially looked at several protein targets just en masse, high throughput. What's going to come up positive? What's going to be a possible marker of interest in these patients? And then once we identified a couple of those, we then ran ELISAs retrospectively on multiple patients to see if it panned out with multiple patient samples, multiple different types of infections, and both of these tests were run at multiple time points to kind of track the expression of these proteins. Okay? So that's where we are, and we'll jump in now to the data. So hopefully this isn't too overwhelming. I'll try to be as thorough as I can. So ultimately, we did get about 300 patients. The patients' samples that we got were from multiple ICUs, as I said, from the SICU in 4400, our MICUs in 83 and 8400, and then the BMT SICU up on north in 7800. In terms of the growths that we got, the majority were actually no growth. So these were what I'm calling negative blood cultures. The positive cultures were largely gram-positive, as you might expect, given the discussion we had earlier about contaminants. And then we had 48 gram-negatives. These 27 mixed and fungal, as I said, we're excluding for now. We are also completed a chart review on the patients to kind of analyze some clinical data and outcomes with respect to these biomarkers, and TBD, stay tuned. Hopefully that'll be in the paper. There's the paper. Okay. The organisms, in case you're curious, that we did identify, we grouped into these multiple buckets based on gram staining and morphology. So gram-negative rods, gram-positive cocci, obviously by and large the largest groups. Then gram-positive rods here I've just shown you just for comparison for how low the frequency is compared to these. In terms of the gram-negative rod group, our most common organisms that we saw were E. coli here in the mustard, and then Klebsiella pneumoniae in the blue. Pseudomonas is here representing the gray slab. We cover for Pseudomonas a lot. Obviously, it's a very virulent organism. We have to cover for it, especially with nosocomial infections. But just note here the frequency relative to these other organisms. And then in our gram-positive group, kind of as we expected based on the literature as well, this light blue bar here, almost half of these were coag-negative staph. So again, kind of would often be relegated to the contaminated bucket unless the clinical picture were different, unless it was 2 out of 2, et cetera, et cetera. And here in the dark blue, we have MSSA, MRSA here in the green, and then the enterococci here in these other 2 colors. So this is kind of the general breakdown of the organisms that we identified in our study. So our proteomics data, don't be alarmed. I will walk you through Mordor, okay? It's fine. So this was a pilot study looking at multiple different proteins at different time points in just 5 patients. So each column here represents a different patient. So these negative controls are 2 patients whose blood cultures never grew anything out, okay? This is a patient who grew MSSA, this is a patient who grew E. coli, and this obviously is E. faecalis. The colors represent a ratio of the expression of each of these genes, each of these rows, which you can't really tell because there's so many, but each row represents a different protein. And the color represents the expression of that protein at the time of the index culture relative to the time prior. So we compare the expression level of that protein at day 0 to like day -2. If that protein is upregulated, if it goes up at the time of the index culture, it's depicted here in a yellow hue. And if it's just the same, or if it's downregulated, it's black or purple, okay? And just eyeballing this, I mostly see purple. I don't see much yellow. and that is less than ideal, but our targets of interest would be those that are upregulated or downregulated, but mostly upregulated, since those are easier to note in these types of assays, in the infected groups, and then not changed at all in the patients who weren't infected. Because that would suggest that this marker would be specific for infection because it's only changing in the infected group. And you can see here that that's basically this little sliver up here. So we see a lot of yellow on these 3 columns here, indicating that these proteins were changing for the infected group, upregulating for the infected group, and not so much for the non-infected. And this is where we kind of focused our attention for the ELISAs later on. All right? So the targets that we decided to move forward with were called TIMP1, or TIMP1, as I shall say, and transgelin. It's the same system as before, where we're looking at the day prior to the index culture, the day of the index culture, and the day after the index culture. So basically 3 buckets of time points. That would be day -1, day 0, and day 1 to 3. And this is a range because, as I said, we don't have the exact same time points for every patient by virtue of the sample quality. Just a little aside on these proteins and why we picked them. Aside from the proteomics data being promising, these have some literature support as well for being possible targets. TIMP1 is pretty promiscuous, as they may say, in terms of its activity with the immune system. So you can see in this figure, in both the innate and the adaptive sides, it has functions in basically every cell lineage. NK cells, T cells, B cells, neutrophils. It does stuff basically in all of these. It's kind of almost a housekeeping gene for a pro-inflammatory state. And as you'd expect, that leads to its elevation in many different conditions, not just infection. There's data showing that it's increased in even the urine and in AKI, in the synovium and even in tissue in osteoarthritis, obviously increased in sepsis states, COVID, et cetera, et cetera. So kind of a more nonspecific marker of inflammation, at least per the literature. Okay? But this is my data. And oh gosh, it's blurry. Okay, this is surprisingly blurry, but I hope you can still kind of appreciate what the data changes, the data depict here. So I'll walk you through group by group. So the gray bar is the control group. These are patients who never grew anything from their cultures in our data set. Comparing the day before the culture, the day of the culture, and the day after the culture, you can see these gray bars basically are all the same. So there's not much of a change in TIMP1 expression across these time points. Switching your focus now to the gram-positive, the blues, intuitively. So you can see here that there seems to be a pattern of an increase in TIMP1 by the time the blood culture is drawn, and then it goes down afterwards, presumably when they're treated. But this did not even come out to being close to significant statistically. And then our last group here of interest is the gram-negatives, and you can see this is what our gold mine is here. We do see a statistically significant, I mean, give me a break, that's basically there, increase in TIMP1 expression in gram-negative bacteremia, bloodstream infections, I should say, that then decreases after the date of the index culture. So this would suggest an almost time-locked, very well correlated expression change in TIMP1 for gram-negative bloodstream infection only, in regards to the actual time of the blood culture being drawn. So it could be a marker essentially for gram-negative bloodstream infection. So that was exciting. Our other marker that we looked at more closely with these ELISAs was the transgelin protein. Has a little bit more of a very narrowly defined role in the immune system. Stabilizes the F-actin cytoskeleton in macrophages to help formation of filopodia for phagocytosis. It's all cool molecular cell biology stuff. You can see here these red dots are the transgelin protein stabilizing the cytoskeleton so that this guy can swallow up some pathogens. There have been a lot of great in vivo studies showing that this is crucial for normal immune function. In particular, there's some studies showing that transgelin knockout mice are much more susceptible to bacteremia, have worse outcomes, et cetera, et cetera. So clearly a pivotal protein for the function of the immune system in mammals. Here are data for transgelin 2 in our data set. So you can see, I'll walk you through again group by group. The gray bars are the controls. Looks like it's going down. This was not significant, but essentially no changes across the different time points here. In our gram-positive group, we kind of start seeing a qualitative pattern, but again, not even close to being significant. And with our gram-negative group, there seems to be potentially sustained increase prior and at the time of the infection, at the day that the blood culture was drawn, that then decreases after the blood culture is drawn. So that decreases after the infection is being treated. So this would maybe suggest that transgel 2 could actually have some prognostic, some utility in telling you when to stop, because it seems like the infection is getting treated and transgel goes down. This is kind of similar to how procalcitonin functions in a lot of clinical studies. But it doesn't have what I think is more special or more remarkable, this kind of increase at the time of the infection from a baseline level, to tell you when to start doing antibiotics, to tell you that there is an infection in the first place. So. But still, I think, an interesting data nonetheless. We have some controls here. This is still a work in progress. But the controls that we're looking at are procalcitonin in our data set with our cohort. So you can see here, like I said, this doesn't even have an error bar. So we're still working on these assays. But there seems, at least for the gram-negatives, to potentially be an increase in expression of procalcitonin with the infected state that then goes down after treatment. This is not significant just because of numbers. But we still need to kind of accrue more data here to demonstrate this. But this is in line with what the literature showed, that procalcitonin decreases with treatment of an infection. What I think is a more interesting and pertinent control is looking at just healthy folks, the levels of these proteins in someone who doesn't have an infection, who's not even in the ICU. We do have samples from outpatient healthy patients, and looking at the TIMP1 levels and the transgelin levels in these patients. For TIMP1 at least, it seems to be a very low level of expression compared to our cohorts, both those who are infected as well as those who are not infected. Of course, it's significant for those who are actually being infected. So even though TIMP1 is pretty non-specifically elevated in just inflammation states, it seems to be even more so elevated in these infection states for us, at least in our cohort. And that could be, as I said, a little bit different from the literature, but still worth investigating further for determining its role in diagnosing a bloodstream infection. Transgelin doesn't do that. It seems like all the levels are the same for transgelin. So it would, in some ways, be a little bit more specific for an infected state than TIMP1. But nonetheless, these, I think, are interesting findings that we still need to kind of flesh out a little bit more with more healthy outpatients. So before you guys just tear holes in my work, I will do it myself. So the first thing is, obviously, this is all entirely an ICU population. These patients are very, very sick. They often have multifactorial illness. And the biggest thing is that they often have already gotten antibiotics by the time that these cultures are drawn in some form or fashion. So that can certainly skew the results. I think it's still very promising that we still got a fairly robust signal, even despite the fact that they may have gotten antibiotics. The collection of the post-culture draws and the adequacy of the sample is, again, something else that limits what we can interpret in our data set. Because we wanted to look specifically at biomarkers that increased before the blood culture was positive and then went down after as well, we're restricted to patients who had blood samples before the blood culture was drawn in the first place. So that means we can only look at hospital-acquired infections. We can't look at a community-acquired bloodstream infection, for example. But that is, of course, a project for down the road. And as I said earlier, some of these patients already had positive cultures before. That kind of skews our data as well. And we haven't yet filtered out by the number of positive cultures. Once the chart review data is completed, we'll be able to run a lot more analyses to kind of correlate with the clinical presentation of the patient. But this, as of now, does include patients that were positive in just 1 out of 2 cultures. I spent a lot of time bashing blood cultures earlier, but that was our gold standard for our study as to whether or not the patient was infected. And these proteins are not really well studied or extensively studied, so the antibody quality is not necessarily the best either. But I think, in spite of all these things, we still saw a pretty clear sign that TIMP1 and transgelin have some sort of relationship with infection here. So long term, as I said, we'll be looking at our chart review now, comparing with clinical outcomes and patient data sets, characteristics to see if there's any other utility of these markers, make some models to account for any possible confounds, and see if there's any prognostic utility to see if these patients do poorer if they have a higher increase in TIP1, for example, than someone else. There could also be correlations with the source of the bacteremia, and as well as the actual, a little more granular details about the pathogen itself. We, of course, as I said, account for empiric antibiotic use, patient characteristics. We can look at whether or not these biomarkers are differentially expressed in a state that's infected by a resistant strain versus susceptible strain. I mean, sky's the limit. There's so many different things we can do once we get some more data here. And I think down the road, of course, we need to examine this more in what we call community-acquired bloodstream infection and non-critically ill patients in many different cohorts to see if these patterns that we're seeing truly do translate there. So all in all, the big things, I know it was a bit of a word salad of data and stuff, but the big things I want you to take away is that we do have blood cultures, but blood cultures are not perfect. There are a lot of assays right now to kind of reduce the amount of time and inaccuracies that we see with blood cultures to help diagnose bloodstream infections, but these are often expensive and can also have their own issues with sensitivity and specificity. We have 2 markers that we think are pretty promising, specifically for gram-negative bloodstream infections that may correlate specifically with the actual infection itself, so that it can help you both know when to start antibiotics as well as when to stop them or de-escalate them. And I think that is huge, especially given the way we treat bloodstream infections now. Of course, our future studies will be reflecting more on different patient populations and looking at different clinical outcomes and patient characteristics to see how those affect the levels of these proteins too. And with that, I want to thank everybody who's helped, who's been instrumental. Jenny and Chris, they've been great C-STAR mentors. Chris is here in the audience. They're lab members as well. Carly and Olivia in the Quan lab have been really helpful, as well as Carrie, in just kind of organizing everything with the chart review. And then Sydney and Brittany have been great in helping out with doing the ELISAs and analyzing that data. And then the proteomics, of course, was done by the MGI, the MTAC core of the MGI, Young and Byung Hugh, so they're also very helpful. As I said, this was all done with the C-STAR funding. If you have any questions, I'm happy to talk about that more. And the residency leadership, thank you guys for giving me a platform to talk, surprisingly, and just rant for my data for 30 minutes. So, and that's all I have.
Thank you both. Those were great presentations. Back up. I think we have time for a few questions. So,
sorry.
Rise and rapid development of technology. So, places like SpaceX can just throw anything at the wall and we're not able to the same level of evidence that we are. So how do we foresee that changing so that we don't fall too far behind?
Yeah, I think in Europe at least, they actually have like a division separate from their general government where they like, as part of their health department, they've incorporated a whole different department that kind of deals with patient data and security. I think, to be honest with you, I'm not entirely sure how far we've come in terms of like our government and regulation changes per se. But I think a lot of it is met with the fact that a lot of these technologies are still up and coming, and that there's not too much data to help guide kind of policy changes to that extent yet. But there is FDA approval for a lot of different technologies now too.
So why did you start looking at a host biomarker and sort of a protein that's associated with inflammatory response versus looking at the pathogen biomarker?
Typically, at least a lot of the assays that exist right now for pathogen identification are nucleic acid based. It's good? Okay. So typically, the question was why use a host biomarker instead of a pathogen biomarker? And typically, at least from the data and the literature that I've seen, a lot of the pathogen-based biomarkers assays are nucleic acid-based, so they're limited by the probes you use and which pathogens you can pick up on, but also they require a certain skill set that a lot of labs don't have right now in terms of nucleic acid testing, and they can be a little more expensive. Whereas protein-based assays, typically for the host, can be cheaper, faster, things like troponin, biomarkers like that. From what I've seen, there's not a lot of great specific protein-based pathogen biomarkers. Things like if you look for LPS, for example, I mean, we have our own flora, so that really complicates that. So we decided to go with the host response, just with a massive screen to see if that could yield any promising targets.
That's great, thanks. Other questions? If not, thank you both very much.